Hello and welcome everyone. My name is Prashant Yadav. I'm a senior fellow at the Center for Global Development. Thank you for joining us for this very interesting event on the applications of machine learning in pandemic preparedness and response, and how can we translate models into policy action. We have a great lineup of research talks and policy keynotes. And then a time for all of you to pose your questions and have some discussion with our speakers and panelists. Throughout the pandemic, the Center for Global Development has been engaged in a number of work streams, many of which are related to how do you get the right data, how do you analyze data for making the right kinds of decisions, and CGD has also been involved in a number of high-level panels to think about the architecture for future pandemic preparedness, financing, manufacturing, supply chains, public health response, and so on. And one theme that we've seen cutting across many of our projects, initiatives, and work streams has been the use of clever data analytics and how it is helping guide both decisions that are being made on response to the COVID pandemic, but also in how they can help us shape our preparedness efforts in a better way. So that's the theme of our discussion today. A lot of machine learning and advanced analytics models have been used to forecast the future trajectory of the COVID pandemic. They've been used for adding as a supplement to more traditional epi models. They've also been used for various clinical and diagnostic applications. Those are not the areas that we're going to focus on today. What we're focusing on is how can machine learning and data analytics be used in preparedness and response in things which are important from a policy action standpoint. The way we've organized the event is we've carefully curated and selected 4 research talks, which will be short 10-minute presentations. The links to the authors' papers will be available for you to delve into greater detail. Those 4 research talks will give you an idea of the kinds of applications, the kind of diversity that we're seeing in the use of machine learning and advanced analytics. And then we will transition to 2 policy keynotes. We'll hear from 2 policy-related people who are deeply looking at some such models and how to use them in larger practice. That will be our flow. So I don't want to waste any more time and want to get started. I will introduce each speaker when they start. And so we'll start our research talk section with first talk by Hamza Bastani. Hamza is an assistant professor at the Wharton School at the University of Pennsylvania in the Department of Operations, Information, and Decision Sciences. Most of her work is focused on the use of machine learning analytics for healthcare and other applications. The particular work that she's presenting has won numerous awards. Hamza has a PhD from Stanford. And with that, let me move over to Hamza. Hamza, welcome to CGD. Welcome to this event. Over to you.
Thank you so much, Prashant. Can you see my slides? I'm very excited to talk to you guys about some work that we did in collaboration with the Greek government, deploying a data-driven COVID-19 border testing tool using reinforcement learning, as well as how we use machine learning to inform travel protocols throughout the summer of 2020. This is joint work with Keynote and Vishal from USC and also the Greek COVID-19 Executive Committee. Like Prashant said, our paper recently appeared in Nature, so I'll only be giving some very high-level highlights now. So the main idea behind what we set out to do is during the summer of 2020, testing resources were very scarce and a lot of countries were opening up their travel restrictions in order to stimulate the economy and tourism and so on. But the key challenge here was that there wasn't necessarily good data to measure travel-specific risk And so what a lot of countries, especially in the EU, but also worldwide, were doing was they were using intuition or kind of publicly reported metrics on the general population in each country, like cases per capita, to try to yardstick these countries and figure out which ones were high risk and which ones were low risk. And then they had all these ad hoc travel protocols that were limiting who could come into the country, who had to get tested, who had to be quarantined, how long, and so on, based on this kind of guess of traveler-specific risk. So the main idea we have with what we deployed in Greece is to actively collect traveler-specific risk data by measuring or testing travelers who are coming to Greece at the border so that we can objectively measure their risk and actually use these risk estimates in order to allocate tests efficiently to people who are most risky, right? Because the goal here was really to catch as many positive cases as we can at the border so that we will be able to ask these people to self-isolate or quarantine rather than going around doing their vacation and spreading the infection amongst the general population. And this approach was really effective in that it doubled the effectiveness of testing. So we were able to catch twice as many infections at the border than we would have had we done something like random testing. And when there was high traffic, this went up to even 4x. And one big insight of kind of the work we did was that yardsticking these countries based on cases per capita, deaths per capita, positivity rates, or all these publicly reported metrics from the general population, using that to assess traveler-specific risk is really comparing apples to oranges. And this was a very frequently used policy metric. And so we think this should strongly be reconsidered, especially now that we're going into the Omicron phase. So let me jump in a little bit into how this was deployed in Greece. So the system was, Greece is a bunch of islands. So we have people coming in through land, air, water, and so on, many different points of entry. 24 hours prior to travel, we asked families to fill out something called a passenger locator form. So this basically captures a bunch of information like where they're coming from, demographic characteristics like gender and age, and so on. So basically features that might inform traveler-specific risk. And this gets fed into our system that was called AVA. This is really the AI component now. So like we said, testing resources were pretty scarce at this time, so we couldn't test most people. This is PCR testing. So the algorithm basically tries to build predictive models of who is most likely to test positive or who's most risky, and then makes a set of testing allocations. And so these people get kind of this QR code, and that gets actually, and then they get to scan that by the border agent, and then they get jump behind a curtain, they get their swab taken, and that gets shipped off to a lab. And then within 48 hours, the lab will return the PCR testing results, and then that gets fed back into our system. So what makes this approach really valuable is really this dynamic feedback loop. So the algorithm is using current testing results to predict who is risky and makes a set of test allocations. Then we actually go test those people. We get those results back, and then we use it to update our predictive models to make the next set of testing allocations. And this is critical because throughout the summer, basically a lot of locations, their risk kind of spiked and then it went back down. So it was a very moving object that we were trying to track. And so we want to make sure that we're agile and we're actually following these spikes and the waves going into different locations around the world over time. And so basically reinforcement learning or any kind of dynamic learning algorithm lets you do this. And that's kind of critical in this application. Right? Next, we talked about from guessing to measuring, right? So I've been saying that if you use publicly reported metrics in order to yardstick countries based on whether they're risky or not, that's really guessing. And what we're doing instead is actually measuring traveler-specific risk. So countries are measuring general population risk. That is not the same as traveler risk. Those are not the people who are coming to Greece for vacation. And it also doesn't account for their demographic characteristics or other features that we might be able to look at. And so what we do is we are actively collecting data at the border in order to form predictive models of who is actually risky, breaking them up into types based on their features, and that way we can more efficiently allocate tests. So let me jump into some lessons. So first of all, this approach, we were able to target different traveler types, doubled our effectiveness compared to random testing. So that means that we are catching twice as many infections at the border than we would have caught had we just tested people randomly. And this is a big win for Greece because every person that we don't catch at the border is going to go into Greece and spread the infection amongst other people, right? And that has strong public health negative consequences. So we want to maximize the number of infections we're catching. You can also imagine comparing this to a policy that's based on publicly reported metrics like cases per capita, deaths per capita, positivity rates. And we find that we catch 25 to 50% more infections at the border with the same testing budget than sort of these policies. So this really shows that these publicly reported metrics are kind of missing something, right? So what we did was we did a simple exercise where we looked at the time series of publicly reported metrics, like the cases and deaths and so on. And we tried to predict based on those metrics, who is likely to, whether travelers coming from those countries to Greece are actually high risk or not. Right? Because that's what Greece cares about. They don't care about the risk in those countries. They care about the people who are coming from those countries to Greece on vacation, whether they're likely to test positive or not. So we did this exercise using kind of state-of-the-art machine learning models like random forests and neural networks. And we basically find that it's a random coin flip. There's no signal here at all. So if you look at the models, we get something like that's a AUROC of a half, which basically means that these are two different populations and they completely are not representative of each other. So what is going on here? Well, like I said, at this time testing.
I'm sorry, can I interrupt you for 1 second?
Yes, please.
I'm just flagging this to my colleagues at CGD. We are getting emails saying that the live stream link is not working. It is saying waiting for CGD video to show up. So I hope we can fix that. Back to you, Hamza.
Okay. Okay, so yeah, we have so this basically ends up being a random coin flip. And what is going on here is that different populations are different, right? So at this time, testing resources were very scarce. And so these high-risk, these countries, they're testing high-risk and symptomatic people, often patients who are at the hospital, right? And that's sort of the general population risk. The people who are coming on vacation to Greece, they are low-risk asymptomatic people, often of higher socioeconomic status as well. And so these populations are not representative of each other. And that's probably why we're seeing that these signals, they don't overlap. Other issues are that, we're yardsticking countries all around the world, even though they have very different resources. So some countries had access to lots of testing capacity and some countries did not. So if we see low cases per capita, that could be because, they're not testing, or it could be that they're low risk. And then finally, there's infrastructure differences. So in some places, there are reporting delays. So we found that for certain places, we would see them spike using our own private data. And then it would take up to 2 weeks before they would actually spike in the publicly reported data. And so from public health perspective, that 2-week delay is critical because we would be letting in a lot of passengers who are high risk without realizing that they're high risk. So that's really the benefit of measuring the actual data that we are interested in. So for machine learning, it's really important that the model is being trained on data that's representative of the population that we are interested in predicting on. If not, it's garbage in, garbage out. And this also has benefits for domestic decision making for Greece. So we set up a variety of these dashboards that the Greek policymakers use to make various local decisions. So we can see, for example, where a lot of infections are flowing within Greece, and they might use that to allocate mobile testing teams or be able to do ad hoc mask mandates and things like that. So that's sort of the value of measuring the right data. So I'll wrap up here. I think I'm out of 10 minutes. So our goal here is really to use reinforcement learning and to use all these machine learning methods. But what's really critical, and I think a testament to the Greek policymakers in investing on this, is that you need to build a central data infrastructure in order to actually collect data in a consistent way across traveler types so that we can compare them in a fair and objective way. Instead, you end up, if not, you end up in this situation where you're comparing apples to oranges, which is really not effective. And in the paper, we talk a lot about how we are actually trying to, we tried very hard to abide by GDPR considerations to preserve privacy, fairness, and so on. And so those are all key aspects to getting one of these algorithms actually deployed at scale. Thank you. This is my email and my website if anyone is interested in following up with any questions.
Thank you, Hamza. Very interesting and clearly lots of questions that we all have related to not just targeted onboard arrival testing, but the whole concept of red listing countries and lots of policy debate around that. So hopefully we can get into some of that during the discussion. Before moving on to Benjamin, I just want to make sure with my colleagues that any technical difficulties have now been fixed.
Yeah, the stream thing resolved.
Okay, thank you for resolving that. Our next, so we are going to do questions and answers at the end, but if you have questions, please keep sending them our way, either through the YouTube channel or through email or through CTDev's Twitter handle @CTDev. If you are tweeting about this talk, it's hashtag CGD Talks. Okay, we'll move on to our next research talk, which is by Benjamin Fells. Benjamin is the CEO and founder of MacroEyes. He specializes in using technology for development in complex settings. He has worked extensively on the use of AI in health. Before founding MacroEyes, he was a derivatives trader and has led a large global trading team. And has written about the use of AI in health in the Financial Times and other media. Benjamin, over to you.
Thank you, Prashant. Okay, I'm going to...
Oh, may I interrupt for 1 second? So I just got alerted from my colleagues that it is still not streaming on the website.
Okay, I will defer to you, Prashant, what you'd like me to...
We have it recording at the moment. We're about to have it fixed. Go ahead and continue.
Okay. Good morning, good afternoon. I'm Benjamin Fells. I apologize if, for my hoarse voice. Hopefully we'll make it through here. So we're going to be talking about infrastructure. And I thought first I'd just sort of frame where does this come from in the context of the company. Fundamentally, our technology aims to shift supply chains from being reactive to proactive. Think about the act of automating this precision matching of supply to demand. Now, because we first deployed our product at scale in Nigeria, in Sierra Leone, in Mozambique, and Cote d'Ivoire, this forced the development of underlying systems for learning from a wide variety of alternative sources of data. Forced this development because we had no other option. So again, today, I'm going to be speaking about machine learning to infer what we think about as the contents and capabilities of each site, each health post that matters, and the health system as a whole. And we call this Strata Infrastructure. It's part of a software product that we call Strata that has 3 pillars: people, places, things. And essentially this software answers 3 questions. Who won't show up for care? Who will? So think about sort of who's going to walk through the front door of that house post. What's there in a very literal and operational sense at the site level? And what will come off the shelf tomorrow? And what will come off the shelf in the weeks ahead? So these 3 pillars of Strata together form an overarching optimization for supply chain. The capability to ensure the right product is at the right place to engage hyper-specific demand. So this work on infrastructure began in Sierra Leone when the Ministry of Health presented the problem of operational visibility. They didn't have a current picture of their health system. They didn't really know where the health system was ready and where it was under-resourced. They didn't know what type of care could or should be delivered at each point on the map. And all of this was framed with the increasing urgency of responding and preparing for COVID-19. Our response, the technology itself, became a product, building on core macroized machine learning. And so this result, what we've delivered to the government, is visibility at the chieftain level, visibility at the district level, and visibility at the site level. And this means information about water quality, backup power, characteristics of the catchment population, staffing, number of beds, continuous learning to provide continuous assessment of the health system as a networked whole, and again, each individual point on the map. So how did we get there? And there's this is probably a conversation on its own. There's quite a few different tools and techniques applied here, but I'm going to talk about just a couple. We deployed a specialized pipeline for learning from satellite imagery, particularly turned towards this problem of detecting solar panels, sort of the last assessment of the state of backup power or any sort of power across the health system for Sierra Leone was 3-5 years ago. The result was an updated MOHS registry of electrification at the site level. And just so that we all sort of understand why that's important, without visibility into backup power, cold chain visibility is incomplete. And not just what's there, but what changes over time. And what does that change tell us about the capability to deliver care, the capability to respond to COVID-19? We deployed a pipeline for change detection, tracking the density and composition of ground cover, again, derived from satellite imagery, month to month. So think about this as sort of high level kind of abstract view of how color and composition changes. When ground cover unexpectedly changes, this can be indication of broader environmental change, flooding, drought, and this can have implications about the capability of a single site to deliver care. So think about learning about what's outside of those walls to get a sense of what might be happening inside those walls. Detecting environmental change or anomalous environmental change triggers queries across the public internet to prove or disprove this thesis. So we have on this page an image in the lower right that the technology found on social media showing what was a bridge. It's now a river. And this bridge was necessary to reach that specific health center. And that bridge is now gone. Neither that image alone or that month-to-month analysis of ground cover told the full story about the content and capabilities of that individual site. Only by layering them together was Strada able to determine the current context for that health center. We see each data set as a point of view, and the greater the diversity of data sets or points of view, the more reliable that view, the more reliable that picture of ground truth. So we're going to switch now to a different but similar setting. California, as we all know, is a very large economy. Operators and decision makers in California faced, this to me is the fascinating part, the same problem as our customers in Sierra Leone. To send resources where they will be used, you must know the condition of each site. Think about it sort of, what can we plug in at that site level? Our customers were tasked with distributing COVID-19 vaccines and tasked with strengthening the health safety net, but they didn't know what was there at the site level. And I would argue sort of that operational visibility at the site level is really what matters most. They didn't know about refrigeration, state of backup power, demand dynamics of the catchment population, so sort of people who were served by that individual site. And like Sierra Leone, California has an unreliable electrical grid. So backup power is very important. As was the case in Sierra Leone, we began with high quality survey data for about 5% of sites. Think of this as beginning with the answer to 5% of the questions. The core machine learning system was then deployed to piece together data sets and make inferences to fill in the rest of the map progressively. As new data comes in, the system continually reassesses how it's labeled each site. And again, learning from satellite imagery, learning from the public internet. And this is how, at least I see it, as machine learning works. You examine examples, you use the example to learn the logic, you use the logic to generate outputs, and you learn from when you're wrong as much as you learn from when you're right. And then you recalibrate, and you never stop learning. Machine learning is uniquely receptive to being wrong and then learning from it. We treated permit data, and this was unique to California, as a kind of ground truth. If a federally qualified health center filed for a construction permit to install a battery or a generator, which they must do by law, and then had it inspected, it's probably there. We deployed Strata Infrastructure in 6 weeks for the state of California. In 6 weeks, we took our customer from operational visibility into 5–8% of sites to operational visibility into 100% of sites. Every federally qualified health center in the state of California, that's more than 2,000 sites. Our customer uses the results, the data, to assess the preparedness of each of these sites. And this means the capability to operate during wildfires, the capability to safely store and deliver vaccines. And this data is also then used to triage interventions into the health safety net to enhance preparedness. Where do we need to install solar panels? Where do we need to send refrigeration? Where do we need to send additional health workers? Health systems often work from data long out of date. And this has, as is probably obvious to everybody, operational implications. It results in misallocation. The status quo, so sort of how do governments address this issue of understanding what's there, is to do some version of a site visit for every point on the map, or rely on self-reported data. The former is impossibly slow or expensive. If we had to visit every federally qualified health center in California and examine the contours of each site, we'd still be working on it. And the latter, self-reported data, has multiple layers of bias. And on the subject of self-reported data, it turns out, at least this has been our experience, that no one in the world likes responding to surveys. And when you rely on surveys, you end up hearing from the same sites again and again, and you end up hearing from the same people again and again. The international community has been investing significantly in cold chain capacity for years. This investment has proven crucial. More is needed, and I think everybody agrees on that. The problem is that comprehensive databases, sorry, I'm at my 10 minutes, I'll conclude here. The problem is that comprehensive databases are missing about refrigeration and missing about backup power for health centers across the world. This results in misallocation and tragic waste. And let me take again this example of a very high income setting so that we can imagine what it must be like globally. Our analysis in California showed that 30% of federally qualified health centers had both adequate refrigeration and backup power. And I want to emphasize that and. Only 30% of sites in what is essentially the wealthiest place on earth. This means that when vaccines and health products are sent to sites that serve the most vulnerable populations in California, and when the power is shut off, which is not infrequent in California, many sites are left with medicine that is no longer cold, vaccines that they cannot or should not use. Macrowise was founded to productize a notion of similarity. Machine learning context-specific measures of similarity or relatedness between people and sites and other sites, places. We've worked on variations of this problem for nearly a decade. This technology enabled us to start with a minority of sites, again, 5% of sites, and then find sites that are similar across multiple dimensions. Then test this hypothesis of self-similarity with other sets of data, and slowly fill in the map and continue to increase the quality of that map. I'd like to conclude with an optimistic idea. We can provide health site level data for the whole of the United States and for the whole world. And we can do it fast, provide every government, provide COVAX a continuously updating global map of the current state of cold chain. We think about this as predicting the present. This would go a great distance towards eliminating wastage of precious vaccines. Again, when you know what's there at the site level, you have a much greater chance of sending what can and should be used. So I will conclude there. Thank you.
Thank you, Benjamin. Very interesting and creative ideas. I, in particular, like the use of permits and building permits as public data sets that can go into predicting what is the state of infrastructure, and also very interesting that the application of such models is not as separate between low and middle income countries and high income countries. Similar kinds of things can be used across. Two things. One is those of you who joined late because you couldn't log in when Hamza was presenting the first research talk. It has been recorded in the YouTube. So if you were amongst the few who could not join in, that portion is available in the YouTube recording. So you can go back to it afterwards. We apologize if the link wasn't working for some of you. Okay. Once again, reminder, questions, keep them coming through the different channels, and then we'll address them towards the end. Okay, so next I want to move to Florin Chiokan. Florin is an assistant professor in the area of technology and operations management at INSEAD, so it's a dear colleague, and he works on a number of things, but in particular, his work has focused on give me just a second, something's popped. Yeah, he's focused on revenue management in non-traditional domains such as advertising and internet marketplaces. He also works on cloud-based optimization. He has a degree in applied mathematics from Harvard and a PhD in operations management from MIT. Over to you, Florin.
All right, so hi everyone, and thank you, Prashant, for the introduction and for hosting us. So when I say us, I mean my co-authors, Sergio Camelo, Dan Yanku, Javier Warren, Spiro Zampoulis, and myself. And what we've tried to do here, well, at least speaking for myself, sort of a new topic, we've tried to give policymakers a tool to think about the effectiveness of targeted interventions for pandemics. And in particular, we've looked at targeted confinements. So, we've all experienced confinements during COVID. So let's think about what kind of targeting we've actually seen being implemented in real policy. And it's mostly been across two different dimensions. So we've seen a lot of targeted confinements of certain activities. So I'm talking about schools or leisure activities, and you close those down to prevent social contacts there, and in turn, infections and possibly deaths. But this has also been complemented by a different way of doing targeting, which is to look at population groups. So you could segment population by age, for instance, and we've seen confinements for senior groups, for youth population groups. More recently, we've also seen targeting based on vaccination status and curfews for the unvaccinated. And something else is also more sophisticated ways of doing targeting, which goes to both activities and population groups, age groups. We call this dual targeting. And examples of this could be dedicated supermarket hours for seniors, but also some confinements that are in principle non-targeted. So in France, there's been evening curfew restrictions for everyone. But you can imagine how these will lead to some implicit targeting, will have different effects depending on your age group and your activity. So this is the kind of confinement targeting that we've seen. And a question could be, why even think about doing this kind of targeting confinements? And the simple answer is just heterogeneity. So heterogeneity in health risks, in economic values, perhaps most importantly, in the social contact rates that different age groups will generate when engaging in different activities. And what I have here is just an example of social contact matrices by age group, but one of them is in work activity, the other one is in leisure activities, and you can see how different these kinds of patterns are. So if we recognize this heterogeneity, well, then we can think about doing targeting in order to potentially exploit this heterogeneity in ways that non-targeted confinements just aren't able to do. And the benefit of this is that we could actually end up with a win-win. So we might, if we find the right targeting, we might be able to achieve health and economic outcomes that are at the same time better than what we could do without targeting. At the same time, there's real downsides to this, significant downsides to this. This would be more difficult to implement, and almost by definition, it will lead to disparate treatment and all sorts of fairness issues. Which is why I think, before even thinking about policy action, it's actually quite important to have a rigorous framework just to kind of understand how much is on the table from doing targeting. And in particular, from doing optimized targeting, because the examples of targeting that I showed you before, I mean, a priori, we don't really know whether they're the best ones or not. But there's a need for an analytical framework, and we've tried to build this. So we have an algorithm that will find the precise targeted confinement on both age groups and activities. So you can think about, under normal circumstances, no one is under confinement, no one experiences lockdowns. But then what our algorithm does is it actually produces a confinement schedule. It's targeted to each age group and activity pair. So this is an example of a schedule that I might produce in the first 2 weeks of a pandemic. But over time, it can also change these confinements. So in the subsequent 2 weeks, for instance, what it might do, as I'm showing you in this example, it could actually deconfine age group 60 to 65, but only in the leisure activity. Okay. And this algorithm, it finds the best sequence of these confinements to actually minimize the economic value that is lost through the confinements, plus the total deaths that occur, but weighted by a cost of death parameter. Okay, so you can think about this cost of death parameter as giving you some kind of trade-off between economic and health objectives. And we are not trying to assign a specific number to this. What I'm going to show you is a range of different cost of deaths, and that's going to create an entire curve of potential outcomes. Okay. But in a nutshell, that's what the analytical framework is aiming to do. And we actually implemented this for the French region of Île-de-France that contains the city of Paris, and it's quite a large region of 12.3 million people. We have an implementation of this. I won't go into any of the details here, but it's actually implemented and available online if you want to play around with it. What I'm going to do instead is I'm just going to cut straight to the chase. So how much is there on the table from doing this kind of more precise targeting? So we're going to compare different levels of targeting in terms of total number of deaths. So that's what I have on the x-axis here. And in terms of economic losses, that's on the y-axis. So if you're going to do the best that you can do, but with no targeting, you'll have this curve here. And remember, it's an entire curve because there's different costs of death, so different trade-offs. And what we want to do now is if there's some gains to be from targeting, the win-win would actually correspond to a curve that kind of sits underneath this one. So if we did some targeting, but only on age or only on activities, there's already some benefits to be gained. But then if we think about dual targeting, so you target both on age and on activities, you can already see that there's really a significant amount that's on the table to be extracted from this. So age and activities targeting will actually dominate all other policies. And in terms of scale, we're talking about roughly 35 to 80% lower economic costs for the same number of deaths or lower compared to the best that you can do without targeting, with blanket lockdowns, confinements. And it will do this by unveiling real complementarities between age and activities. In particular, how much you gain via dual targeting is greater than the sum of the gains from only doing age targeting or only doing activities targeting. So there is actually really a win situation here. It applies if you benchmark yourself versus other kinds of confinement policies that resemble practice. And another metric that might be interesting for policymakers, and that's a good side benefit of what we're trying to do here, is you could think about the time in confinement that's experienced by each population group, each age group. And actually it turns out that via this dual targeting, you can generally reduce the time in confinement that's experienced by each population group. Okay, so there will be heterogeneity among them, but each one will do better than without targeting. So the other thing that I want to talk about is I want to touch a little bit upon transparency and explainability of such a targeting policy. So we have a fairly complex algorithm that produces these decisions. But what we found is that there's actually a pretty explainable mechanism for how this algorithm actually makes these decisions. So in particular, there's a fairly simple and transparent metric, which we call econ to contacts. And this depends on the age group and the activity that you're talking about. And it's just the ratio of economic value that's generated by that particular group and that particular activity, but then divided by the number of social contacts that are actually generated there. Okay, and again, social contacts will translate down the line into infections and deaths. So basically, to sort of explain what the algorithm will do, you just look at the cost in terms of social contacts, in terms of pandemic risk, for every dollar that's actually generated in terms of economic value. And there's some machine learning that makes this rigorous. But the simple ratio will actually explain the confinement decisions of the algorithm just orders of magnitude better than using age group or activity themselves as characteristics. And I think this is quite an appealing feature in terms of public policy, because it arms a policymaker with a way to transparently explain decisions, and something that depends directly on the health risks and economic features rather than a population-specific identifier. So, what we've done is, I think, showing that there's enough data out there to actually get quite sophisticated and quite precise about thinking about these kinds of decisions. And we'll just leave you here with some of the things that we've learned from this project. But just looking forward to the discussion and any kind of comments that you might have about this work. So thank you again.
Thanks once again, Florian. For some of us who have lived the confinement rules, which were blanket confinements, have always asked ourselves, I don't go to the high social contact activities. I'm in that age group that you are wrongly targeting. So we all can associate with the benefits of targeting, but it's good to see that it is both robust and is not a black box. It can be explained by policymakers. Okay, so we'll move to the next talk, which is by Nita Madhav. Nita is the CEO of Metabiota, which is a company she'll tell us more about the work that Metabiota does. She has 15 years of experience in probabilistic modeling and risk assessment, mostly around modeling infectious diseases, their spread and economic impacts. She worked with the special pathogens branch of the US CDC. She has a bachelor's in ecology and evolutionary biology from Yale, public health master's from Emory University. Over to you, Nita.
Thank you, Prashant. Really excited to be here today and to talk to you about using pathogen event catalogs and analytics to predict the frequency and scale of future pandemics. So we're going to zoom out a little bit, thinking a little bit beyond COVID. You know, our company, Metabiota, we specialize in data and analytic tools to assess epidemic risk, to provide policymakers with the information that they need to make decisions on how to be best prepared. We also work with governments and corporations to better be responding to this risk. So we do use quite a number of big data tools for this work, including natural language processing, machine learning, but today I'm going to focus on the large-scale simulations that we use to really assess the frequency and severity of epidemics and pandemics in the future. So one question that's been coming up a lot, even as we're still in the midst of COVID, is what is the probability of another event as damaging as COVID? And, you know, is this like a 1 in 20 year event, a 1 in 50 year event? And this answer is very important. I think we're all familiar with the panic and neglect cycle where there's a large event, everybody is responding, and then it falls away into memory. And we all hope that this doesn't happen for COVID, but these types of questions about how likely are these events and how important are they to prepare for are very important. So we use this type of information for preparedness, for financing, and to really mark the urgency and priority of taking action to mitigate the risk. For certain types of hazards, there are well-characterized historical patterns and a constant risk. So historical data can be used to provide a reasonably good estimate of future risk. But for pandemics, these are relatively rare events with large variation in severity, a very skewed distribution of what can happen. And then furthermore, we also have biases in observed data. I think we heard a lot about that earlier today and with some of the other speakers. So here, when we're thinking about pandemics and catastrophic risks, this is really in the tail of the loss distribution. And this has a very strong influence on the potential expected value of losses in these events. So normal losses, things that are happening on a regular basis, everyday things, oftentimes you may think of them as endemic diseases. These are reliably quantifiable. There is a lot of data every year. The information's coming out about that. I mean, we can talk about underreporting and ascertainment issues, but compared to something like a pandemic, these are catastrophic losses. They happen much less frequently, and they're difficult to quantify because they're underrepresented in historical data due to the limited sample size. So when there's a rich historical record, we can often rely on the empirical data, but for something that's happening with a handful of events over a long time frame, modeled catalogs are really going to offer an improved view on the historical data. We do rely on historical data and scientific understanding to inform parameter estimation. And one thing that's really happened as a result of COVID is that there is a large amount of data that, that can now be drawn upon. But we still have to fill the gaps in this historical data, and this will be what provides a more robust view of the potential outcomes. It's also important to account for trends over time. When you're looking over a long time horizon, events that happened even 20 years ago happened in a very different context, and we do have to take that into account as we're thinking about what the future risk may look like. And the technique of using modeling tools really does help us to understand and quantify the tail risk and to really show the types of events that could be perhaps not imaginable, but the modeling could point to certain events that are much larger than we might expect. So just to give you a sense of the historical record, the types of events that we look at, such as those caused by filoviruses and Ebola or Marburg, novel coronaviruses or pandemic flu, these are a handful of events over the past 50 to 100 years, whereas our modeled catalogs would contain hundreds of thousands of simulated events and also account for the current conditions and population mobility and medical technology. We do have a report that we put out with the World Bank earlier this year that talks a bit more into detail about the situations in which an empirical catalog versus a modeled catalog would make the most sense to use. So we're really drawing from techniques that have been applied in other types of perils or disasters, such as hurricanes, earthquakes, floods, and wildfires, a branch of modeling called extreme events or catastrophe modeling. This can be used for infectious diseases as well. And again, here we're really needing to use some complex models that are computationally intensive, but also have many parameters to estimate. And then we have the additional component of human behavior and movement patterns that are going to influence how these events unfold. So again, we're trying to estimate the frequency of these events happening, the potential losses, and also these can be used to quantify the impact of early action. We create models that are disease-specific, stochastic metapopulation compartment models that estimate global spread of these diseases via a simulation approach. And we incorporate a wide variety of data, including data on the emergence risk of where these events may actually first start, preparedness levels in different countries, the types of public health interventions that can be implemented, and also travel patterns that would dictate how spread occurs from person to person and place to place. These catalogs that we develop contain thousands of plausible simulated events, and these are based on epidemiological parameters that are embedded into these models. We then use actuarial analytics to derive a likelihood of occurrence for each event that we simulate over a given period of time. So the process, to just go into a little bit more detail on the advanced analytics we're using here, include a disease spread model, which I think most people are now familiar with the traditional epidemiological compartment models, SEIR models. These take it several notches ahead with the global spread, thousands of subpopulations globally. We also have a lot of different parameters that we estimate to try to look at the spread, because we're trying to look at the wide range of possible scenarios, even those that may be more frequent, those that may be less frequent, and those that may go beyond anything that we've seen before. We incorporate preparedness, as I mentioned, and then we're also incorporating the demographic information, the timing between events, the place that it may spark first, and then we do the risk analytics on this to estimate exceedance probabilities and the expected human and economic losses. So I could spend a whole hour on this, but we don't have this much time today. But the disease spread modeling component in itself has many different pieces to it. We're looking at wildlife to human spillover. There's a lot of work that's been done on this, and we're able to leverage some of that. But sometimes these don't exist, and we have to create them ourselves as well. The disease spread modeling, SCR kind of model that I talked about, epidemiological spread. Mobility networks are also built in, and then the preparedness levels of the different countries. And as we've seen, I think there's still a lot of work to be done just looking at preparedness. As we've seen, preparedness does not necessarily equal response. And so I think trying to understand where other factors may play a role will be increasingly important as we move forward and take the lessons learned from COVID. Once we run all these high throughput simulation models, drawing randomly from the different probability distributions that are informing the initial conditions of these events, we simulate them to form this catalog. And this enables us to then make a probabilistic view of the risk, looking at metrics such as exceedance probability, the expected value or average annual loss, as we see here. This estimator, the exceedance probability, is widely used in actuarial science, and we've been applying it now to epidemic and pandemic risk to predict the frequency and severity of these types of events. So if we were looking, once we've developed this entire curve, a lot of this, all this simulation modeling, very rich simulations that we do kind of distill down into this one curve, we can look at the probability that a certain severity of event will be exceeded in a predefined future time period. So for example, if we wanted to know the probability of seeing an event with 5.3 million deaths or worse in any given year, that is the type of information we can find out from this. And so we've looked it up here with the annual exceedance probability of being something like 2.5 to 3.3%. And that's actually the answer to the question that I asked at the beginning, which is what is the likelihood of seeing a COVID-19 level event? There's been a lot of talk that this is a once in a century pathogen, but this unfortunately is not the case. As of December 14th, there's been approximately 5.3 million reported deaths globally. And based on the simulation modeling that we've done, this does equate to a 2.5 to 3.3% chance of an event of this severity occurring. So that means the imminence of the next event is sooner than a lot of people may think, and therefore just underlines the fact and underscores the fact that preparedness for the next event, it's never too early to start. So, the other point here is that these risk estimates are not immutable. Through different types of investments and policy efforts towards mitigation, improved surveillance, improved health infrastructure, spillover risk reduction, all of these things can play a very important role in reducing this risk. And that's really what we want to see. We want to see this risk reduce the next time we do this analysis due to better and improved situations in mitigation, surveillance, et cetera. So for the future, we've always been passionate about moving from the reactive to the proactive approach to infectious diseases, epidemics, and pandemics. And we really see the future in being able to harness these advanced analytics to identify appropriate data sources and gaps in the data, really making improvements in the frequency of the data, the quality of the data that's out there that's being generated, and also constructing these simulation models, running them, and being able to use them to inform and test contingency plans, as well as other types of planning and preparedness efforts. We see that the future state, we hope to see that these will be always on systems. A lot of times we see that systems are stood up during or in the wake of a large event, a very reactive approach, and it doesn't need to be that way. We can have systems that are on, and ready to ramp up when needed, but never kind of getting dormant. The rapid feedback and closed loop optimization are going to also be critical for training the models, the preparedness and response efforts. And we wanted to be able to detect and characterize outbreaks at machine speed rather than human speed. And I think we're seeing, a lot of very encouraging results and information from the speakers earlier today at how we're moving towards this machine speed approach. And then one lesson I also want to mention and leave you all with from machine learning to the current policy debates is we also don't want to overfit our solutions to COVID-19 because the next pandemic undoubtedly will be different. There are many different flavors of epidemics and pandemics. And so we don't want to be overly tailored in fighting the last war or the current war, when we're thinking about the future. So that's all I had. So I'll stop there and look forward to any questions and further discussion.
Thank you, Neetha. To everybody who has joined us, keep the questions coming in through the different channels. What we're going to do is you've heard four distinct research talks, which hopefully give you a breadth of the application of such machine learning models. Now we're going to transition to our policy keynote section, where we will start with Marie-Lise Grogens from the World Bank. She's the lead for health innovation and health emergency preparedness response to the World Bank. Lots of work in digital health, artificial intelligence, is both in academics and mathematical modeling, but also in practice in management consulting, private sector, government of Malawi. So Marie-Lise, over to you. Marie-Lise, we don't hear you.
Excellent. Thanks very much, Prashant. Can you hear me now?
Yes, thank you.
Excellent. So thanks very much. For those of you who feel maybe a little overloaded with all the quantitativeness and all the excellent data and analytics that have been presented, as Prashant said, my few thoughts that I want to share this morning is it really has more of a policy and application focus. So if you asked me before the advent of COVID-19, what I would consider as being important things to keep in mind if we want to translate analytics into policy action, I would have said that from the World Bank's perspective, there are 3 lessons that we've learned that we think are absolutely essential. The first is to have both champions and capacity in governments to participate in the process of formulating, taking a policy challenge and formulating a research or analytics question, as well as interpreting and translating the results from an analytical process, be it machine learning or other analytics, into policy and programs. As we all know, that's part art and part science, but without having a champion in the government and the capacity in the government so that the results that are presented can be internalized, it's very difficult and we see little uptake. The second point, which is related to the first, is the importance of early engagement. In other words, we want to make sure that we don't do modeling and analytics work and machine learning, be it real time or kind of more predictive models that provides that goes to a government, collects the data, and a few months later provides the answers or the analytical solutions. We want to make sure that governments are involved early on and in an active way. And third is the area of metrics and translation. Again, those two are closely related. What we have found at the bank when we commission analytical work is that our most successful analytics efforts are efforts where there are clear metrics to define not just what the policy question is that we're trying to provide insight into, but what is the metrics of what success looks like. For example, if we do an allocative efficiency model to try and reallocate resources in the health sector, financial resources, to the most efficacious interventions, do we go back and check whether budget allocations have actually changed and what was the process from the model results or the analytic results being presented to the model being the results and the outputs of the analytics effort being uptake into policy and practice. So metrics and measurement on the back end of the analytical effort is often not just insightful, but predictive of the success of that analytical effort itself. Then came COVID. Just a little bit of background about the extent of the bank's support for COVID. As of the annual meetings this year, $157 billion to countries ranging in a range of different areas, from saving lives, protecting the poor and vulnerable, supporting business growth and job creation, and rebuilding in better ways. That translated through the different institutions of the World Bank Group in commitments from IDA, our fund for the poorest countries, commitments from IBRD, our fund for and concessional financing mechanism for middle and low income countries, as well as financing through our private sector arm, the IFC, and guarantees for loan guarantees through MIGA. I want to share with you 3 experiences and what are some of the policy takes on these experiences of where we have worked with governments in relation to COVID-19. The first is in the area of COVID-19 mathematical modeling. Secondly is in the area of helping countries to understand vulnerability to COVID-19. And thirdly is in helping countries design and use analytical and predictive planning tools to plan and implement their COVID vaccine response. Across all 3 of these areas, I would argue that the lessons that we learned that could be useful to this discussion are, the lessons that we learned that could be useful to this discussion is just how long it takes and the amount of effort that's involved between the output of an analytics effort and the actual uptake of that analytics effort into policy and practice on the back end. And on the front end, the amount of time that it takes to get data, to get accurate data, to get permission to use that data, and to clean that data. And any data scientist who's either sharing with us or represented today, I'm sure will agree with me that any of these analytics efforts are really bookended by these 2 processes: cleaning, curating the data on the front end, and on the back end, translating the analytical findings into policy and practice. This is a quote from Neil Ferguson, who I know many of us know, who produced some of the very early COVID mathematical models. I think the added dimension that we saw during COVID is just the intense media and otherwise social interest in the results of the analysis. I think because people felt the impact to their lives or potential impact to their lives that much more direct. But I don't think there are other analytical or mathematical modeling efforts where we've seen responses such as email accounts being bombarded with 1 million emails a day based on the results of an analytical process. In the work on vulnerability to COVID, we had done work to help countries estimate the geographic and subpopulation vulnerability to COVID-19. And I think our overarching experience in helping countries do so is that it is useful, but often the analytics results come too late. And they come too late because vulnerability changes, but also because on the front end, it just takes that much time to actually get access to the data. And as we know, particularly in a fast changing environment such as COVID-19, with so much new data being available every day, that if we're too late, then the ability to influence policy and practice is significantly diminished. And lastly, in the area of COVID vaccine planning and implementation, I think at one count, I was part of 7 different working groups that were trying to design tools, software tools to help with COVID vaccine rollout and planning and implementation. What we've seen in our client countries that have used bank and other financing for COVID vaccines is that the tools that they've often reverted to are the tried and tested tools that they've used for routine immunization, not necessarily because they're better, but because they're more familiar. And I think there's a really important lesson to learn here about trying to introduce new tools and new approaches in innovation at a time of crisis when the focus is really on implementation. I think more broadly, if I talk a little more in depth about the first bookend, the front end bookend of data, we know and we've seen, particularly in COVID, the potential that data has to improve lives. But we need to find a balance between incentives and value. We need to find a balance between creating incentives for data use and analytics use and bringing value in a way that is equitable. The World Bank's World Development Report of this year is in fact about data for better lives, and it suggests that there are 5 important things we need to keep in mind when we think about using data for better lives. We need a new social contract for data that is based on value, trust, and equity. And I think in COVID, we've specifically seen the importance of not just value, but trust, and making sure that the data and the analytics that we have and the underlying data on which it is based is equitable, and that access to the analytics is also equitable. We know that we still have a long way to go on data governance, and there have been several in the health sector, several health data governance principles that have now been espoused. There's a recent Financial Times Lancet Commission report on data governance as well. So this is really a hot potato topic in the world of health data at the moment. We know that data governance has economic implications and that it's a matter for international cooperation. Think about a telemedicine service that delivers, as a doctor in country 1, that delivers a service to a person in country 2. And I think this was mentioned earlier, because the front end bookend of getting, curating, cleaning the data is such a time-intensive task. This notion of an integrated national data system that will ensure that a subset of data are available for these purposes, these different analytical purposes that all the speakers alluded to today is really important. Let me just end by saying that the 3 lessons at the top that I would have espoused to be the cornerstones of what does it take to translate analytics into policy action before our experiences with COVID still stands. But I also think that there are other important and additional factors we need to take into account if we really want to be serious about translating analytics into policy action. The first of those is the importance of data systems that I just described. Second is in the area of governance and institutions. I think about Benjamin's presentation about the cold chain and the real-time of the availability of almost real-time data about the state of the cold chain system. where the rubber hits the road and where that intervention really succeeds or fails is in the extent to which the data generated through this engine influences actual practical implementation on the ground, influences where a district health management team might send a person to go and check on the cold chain, how feedback about the functioning of the cold chain feeds back into the model itself. So governments and institutions, to make the link between analytics, evidence, and implementation are absolutely critical. And I think that if we want our analytics to be more impactful, that's a space we really have to work on. Third is the notion of building early and being ready, so that it doesn't take a crisis for us to implement innovations. And we all hope and are working hard to make sure that some of the innovations that we've seen come to the fore during COVID-19 don't fizzle out as the world transitions to a post-pandemic world, but that we build on those innovations and that we scale them to national and global implementation as might need be. A global early warning system, for example, that operates like the global air traffic control system is one example of where we can build early and be ready. The fourth area is in the area of community, trust, and culture. I think we've seen through all the mis and disinformation concerning COVID, some of that relying on analytical results that got not correctly interpreted in different ways by different stakeholders. That at the end of the day, if there's not trust between citizens and scientists and government, it is really hard to translate analytics into policy efforts. And lastly, just to say that particularly in a pandemic environment, we have to build for the future, but we also have to focus on quick wins. Some of our clients' most prolific requests in COVID vaccine implementation has not been for the more sophisticated planning tools, but has been for simple dashboards to help them visualize quickly and easily where what is being implemented. Not suggesting that the more advanced tools are not useful, because they are, but we have to find these quick wins as we build bigger and better for the more comprehensive tools that are available as well. Thank you very much.
Thank you, Marlies. That was a great way to put 4 of our research talks in perspective and think about how they translate into policy action. We had an entire spectrum, one which is national scale use in Greece now, which has been the sort of de facto system, others which are working at a state level or a region level, and Metabiota's work, which is global. So I think we have a full spectrum of this. So thank you for reminding us what is needed to translate some of this into larger scale policy action. Staying on that theme, our next policy keynote is by Kai van der Horst. He's a managing director at the Pandemic Prevention Institute at the Rockefeller Foundation. Before his current role, he was in academia at Penn State, where he created and led a lab which was focused on advanced biorisks. He's also the co-founder of the Global Pandemic Response and Preparedness Alliance, and has advised a number of country government senior leaders, UN agencies on issues related to novel pathogen risks and pandemics. So welcome, Kai, and over to you.
Well, thank you very much for that. It is really a pleasure to be here today and to have listened to all of you kind of shaping out where you have gone and what you're thinking about. And I'm going to talk today about how we as Rockefeller Foundation, actually as Pandemic Prevention Institute, who's just 7 months old, but we are building really on a 100-year history of Rockefeller Foundation building global health capacity and our ability actually to serve as a global neutral convener to work on co-creation of a global emerging disease intelligence and forecasting system. So I'm going to try to talk about how we're thinking about doing this, how we engage partners globally, how we shape relevancy, and how we seek to build this out. Oops. Oops. Oh. So our objective is to build the world's most comprehensive, integrated, federated, transparent, and accessible and equitable infectious disease intelligence forecasting system, with the goal of sharing and collection data and creating a trusted early warning system and giving models and tools, make them accessible globally and relevant. Let me talk about this in a little bit more in this somewhat complicated slide. Right now, a lot of the focus is really on discovering emerging variants. This is really what I call right of boom. This is basically about, yes, we know there is there's a virus, we search for the variants, we try to respond to the variants. But how can we, and Nita was talking about this in a very excellent manner, how can we shift to what we call left of boom, to understand what is coming? Where may we actually see emerging infectious disease that has high consequence impact? And it needs to be at the intersect of human and veterinary health. We do know that 70% of all novel viruses are zoonotic viruses. And when we look back, Ebola, SARS, MERS, all of these, Nipah, all of these are zoonotic viruses that really have affected us. So that is the focus. But how do we discover this? Of course, you need to use real-time biosurveillance, event-based surveillance, sentinel surveillance, but you also need to look at the historical disease data and burden. You need to understand what is in the -80 freezers that basically can be analyzed by these apex international institutions to look at what kind of diseases have been around and how does this correlate to events that have been happening, such as changes in weather patterns, climate change, human migration, deforestation, social media, mobility, basically this, what we call alternative data, which is queuing data to inform about a potential emergence of an outbreak. And then of course you have your traditional data systems that are the underlying framework that need to be kind of drawn upon. Important about this is you cannot create in a vacuum. You need to co-create with partners that have very different types of settings in order to be relevant, to be creating a system that is fit for purpose, that is sustainable, and that's equitable, and ultimately pathogen agnostic. Now, that's very aspirational, but regardless. Because these tools need to inform at all levels, and I'm talking about the community level, I'm talking about the state and local, at the regional and supranational level, preparedness and prevention at different kinds of instantiation, inform medical countermeasures. Basically, how does a system like that inform novel therapeutics, novel diagnostics, and assays for genomics and PCR and so on and so forth to be relevant. Then the issue came up about accurate risk assessment. How to use accurate risk assessment to do accurate risk communication, a challenge we've been experienced during this pandemic significantly. It's a huge problem. And then, of course, because it goes into belief systems, behavioral change, and so on and so forth. And then how do we leverage novel solutions and tool sets to adapt to these new challenges? So I'm going to talk briefly about the global partner network that we've established, but then I'm really going to focus in on what we call regional anchor partners and co-creation partners, because they are really at the center of this evolving paradigm. Enabling anchor partners really are located, these are apex international scientific institutions, health institutions, but they're all placed in uniquely diverse ecosystems that really are conducive for the discovery of different emerging infectious disease. We can get access to heterogeneous data. They are qualified as a co-creation partner, but also when you think about a hub and spoke model, they can proliferate out best practices to networks in the region. So we can establish a common framework, a reference framework, and they can serve as basically the co-creators and validation testbed and innovation hubs. And what I would like to say is that when we look at the platforms that were even presented here, might we imagine that we actually implement these in these different types of settings and check on the availability and the end user adoption. So when you look at our global network, the countries in green are where we have built significant genomics capacities, whether that is the US accelerator, genomics accelerator, but that's the Africa genomics network around Stellenbosch University, ACED, and ILRI. I'm very proud to say that Stellenbosch University, under one of our grants, and other grants, of course, as well, discovered the recent Omicron variant. So we're very proud of that. We have a large genomic surveillance network in India. And then, of course, the Coney Alliance. The countries in blue are countries where we see expansion within the next 6 months. What I really want to train your eyes on is those red dots. These are the Gorgas Memorial Institute, Institute Pasteur Cayenne, Institute Pasteur Dakar, ACED, and going across the globe, CCMB in India and Mahidol, and of course others. They are all chosen because they're uniquely different and can serve as validation platforms for what we are trying to do. So let me just talk you through one. I know my time is short and I talk too much. But Gorgas Memorial Institute in Panama is one of those partners, has been around for 80 years, is a reference center, has BSL-3 capacities, but is located at a unique spot in the world, which is called the Darien Gap. The Darien is a location where we see hundreds of thousands of migrants from all around the world come through. We see very, very high biodiversity. We see underserved by indigenous communities, and dilapidated health and care infrastructure. So really unique potential for from pandemic and epidemic emergence. What is key around here when we start looking at RNA viruses, but also here you look at this unreadable pie chart, which is from 2014 to 2019 for samples collected at the Darien. 50% of those acute febrile illnesses have an unknown etiology. We really simply don't know what that is. And that is a very concerning thing, especially because we are seeing emerging RNA viruses in the region that haven't been there before. And so we see that change happening. So the same thing and very different type of setting is Institute Pasteur Dakar. Very much different in terms of setting, not tropical, but basically an arid climate. We see a lot of emergence of vector-borne diseases, pathogens widening due to migration, people, climate change, and we're seeing viral hemorrhagic fevers showing up. And this is of real concern. But again, testing a systems model in a Gorgas setting versus an anchor like Pasteur is very, very different. And so we need to, when we build these systems out, we need to have relevancy, because that's the only way how we maintain fit for purpose and sustainability. This is just a surveillance structure that we're using with Gorgas to do discovery, looking at bringing a human veterinary surveillance data together, leveraging tools like metagenomics, genotype to phenotype, deep sequencing, animal pathogenesis to do novel virus isolation, and so on and so forth to feed our predictive forecasting system. So, but let me talk, and this is my final slide, about some of the challenges that we've seen. I mean, even recently, with the Omicron emergence and our partners at Stellenbosch University immediately sharing this data, they shared the data and then there was immediate punitive action by shutting down borders. This can't be. This is exactly the type of thing which prevents future data sharing, which is so critical and essential to facilitate the future early warning of a system. So what we are looking to do is leveraging the system we're building, novel decentralized machine learning tools to allow for federated learning at scale across multiple countries without pulling the data, the actual data. And we're using industry-based systems, meaning specifically AI machine learning tools that were used for financial applications from Wall Street to build these federated systems up, which is very exciting. So federated learning is just a recent development for decentralized machine learning. It is often used to train machine learning models using multiple data sets from stakeholders who may not be willing to actually share proprietary data, such as financial data, right? People are very protective about that. Instead of gathering data into a sole source data system, data across the stakeholders really remains within the systems, and algorithms, though, are shared between locations for training. So we are trying to not integrate broader. We really, at the data level, we really want to get to the signal. So the goal of this approach is for each participant to benefit from a larger pool of data, resulting in increased machine learning performance while respecting data ownership and privacy thereby, right? So our platform, we hope, allows our partners to create models on their own because we transition the model and the machine learning capacity into the member countries, whether shared or in-house, and to share those models for others to refine their data sets because it is common learning that is cross-leveraged. That way, data sovereignty is preserved. And we really believe that a successful implementation of federated learning could hold really huge potential for enabling pandemic prediction at scale. So thank you for that. And thank you for allowing me to go last and listening to all this fantastic input. It was truly a pleasure. And thank you for letting me get some extra time.
Thank you, Kai. We are a little bit over time, but I have two questions. One which came from the audience and is for Florin. It is asking, is the work that you described, is that hypothetical? And if it is actually implementing from real data in the region, where does this data come from? So that's a question to Florin. And then I have a question that I want to pose to both Marlies and to Kai, which is using Marlies's analogy of the two bookends, the ability to get the data, to build infrastructure for the data, then the analytics and the modeling and the AI and the ML works, and then the output from that goes into simple, easy to understand, non-black box models that policymakers can use. Do we have an architecture that allows these two bookends to be managed so that modelers and people who specialize in building machine learning models feel I can plug in my work here and get both the access to the data and on the other side, see some output going out? So let's start with Florin. A quick response, Florin, to where does the data come from? Is it hypothetical? And then we'll go to Marlies and Kai.
So yeah, thank you for the question. So the short answer is it is not hypothetical. So we've actually built a data-driven model of Ile-de-France, and then we've optimized it to show you the results. And maybe the longer answer is there's a couple of different pipelines of data sources that we're using. So we're using real-time hospitalization data, social contacts data, Google mobility data, and actually even economic sentiment data. So there's real data that's actually going into the model and fueling these predictions. So, yeah.
Thank you, Florin. And I presume that detail is available in your paper, the links for which were shared on the YouTube link. So hopefully people can look up the details.
Certainly.
Marlies. Thank you. Marlies.
Thanks, Prashant. I think that what you've described as an aspirational goal, it doesn't currently exist, but I think we definitely urgently need to work towards that, which is why, the front book end, this concept of an integrated national data system is such an important building block. I find that there is a lot of noise and discussion at the moment about global health data trust, right? And whereas I think at the global level, it's not bad to have such a global data set available. We have to make sure that it's built from the bottom up, right? I just fear that we're going to ask developing countries for their data and then some external agency is going to have control over it. And that situation we obviously want to avoid. So I would like to think that in a decade from now, if you ask me that question again, I can say, yes, absolutely. We have the systems for modelers, for policymakers to make it clear what are the questions that are important to us, for analytics and modeling teams to answer those questions, and then for policymakers to take those results, interpret, translate them into policy and action. But we're not there yet, and it's definitely an aspirational goal. Thanks.
Thank you. Kai.
So yes, very, very difficult challenges you're putting out there. I mean, frankly, first of all, let me answer from my perspective, it's really, really important to create a system that is open, that's transparent, accessible, and allows people to plug in. There were multiple efforts going on, and this goes back to even the US biosurveillance ecosystem to build a cloud-based kind of partnership and infrastructure across scientists across the world to use models online to build this out. That is very much the goal. And coming back to this data sharing thing, I think that based on the experiences that low middle income countries had over the last 2 years, there's very much a disincentive looking forward to kind of openly sharing data right now. It's more of a, I think we're seeing more and more of a shutdown. And that's very sad to see. So we need to look at novel approaches. And this is why we're but we are pursuing really federated data sharing and federated learning and creating a global community to actually build this out and building capacities out to allow for modeling and to make it fit for purpose and relevant to the setting where people are in, because otherwise it's not sustainable. It will not create the output and tools that are needed to make decisions at the point of emergence. So huge challenges ahead, but building now and building in partnership with our partners in the Global South, and in hearing and listening and not determining what is needed from our side, but actually getting the direction and creating that co-creation is the essential way to go from my perspective.
Thank you, Kai. Once again, thank you very much to all of our speakers. Great discussion, 4 very interesting research talks, the papers of which are available if you want to delve deeper or you want to reach out to any of the authors with further questions. I'm sure they'll be glad to connect with you. Very interesting talks by Marlies and Kai to see what can we do to translate some of the modeling work into policy action at larger scale. I am excited that on one side, there is research that's progressing and is doing the hard work in getting the data, the social constructs of seeing some of their work implemented at large scale, for example, in Greece. And on the other hand, there are people who are working to build the right architecture where this can happen at larger scale in the future. So I come out of this quite optimistic, even though there is a lot more work that especially the data modelers and the analytics groups have to do to connect on the 2 sides of the bookend, as Marlies very aptly put. With that, I want to thank you all. Thank you, everyone who joined. If you had technical difficulty in the first few minutes of the session, this is recorded. You can watch it on YouTube. Thank you for staying a few minutes extra with us. Thank you again.